Today we have a guest speaker. Unfortunately, I think I caught her. No, her name's there. The title is The Golden Burden of Alzheimer's. Deborah OConnor works currently with the Alzheimer's Association of Orange County, and she's Vice President of Programs and Education. And we have somebody in class today who's working at that agency. After her presentation, we will do our usual review of core and cross-cutting themes in public health as they relate to Alzheimer's disease and dementia. And then, but before she comes, she's coming at 2 p.m., we will discuss some of the issues that arise with respect to writing grant proposals, which is your next and hopefully final writing assignment. There are other assignments that that should be on your radar. You have to do a PowerPoint presentation, and I'm still going to be discussing with our TA, Shar, about how best to organize that. But I'd like to see as many of them as possible. But the review and the point will be based on the actual PowerPoint file that you put together. Of course, we'd like to evaluate presentation skills, but the content is much more important. So I'm going to be sending you a template for the PowerPoint slides. So while we're in this period of review, are there any questions that you have about the course, about what we've talked about so far, the speakers, your practicum site? Things are generally going well this quarter, but there are always concerns and problems at some sites. Anyone having problems at their sites that they'd like to share publicly? No? Is anyone here from, is it Earth Resources Foundation? They're not here. I hear there are some problems there. Okay, since you don't have questions, let's think about what we talked about last week. So read this mission statement and tell me what agency do you think this belongs to? Collaborating to create the expertise, information, and tools that people and communities need to protect their health through health promotion, prevention of disease, injury, and disability, and preparedness for new health threats. So if you're working at a public health agency and you're looking around for somebody to support your agency's mission in terms of financial aid or resources, and you're looking through all the agencies and you'd like to know which one fits, you should recognize this mission statement immediately. The Center for Disease Control and Prevention. Okay. This is the agency that's responsible for, primarily for preventing disease in the American population. But they also do a lot of emergency response. They are an asset to World Health in the sense that if you have an epidemic or an outbreak anywhere in the world, this is the agency that has the personnel, equipment, methodology to respond very quickly. And they do share these resources with many, many other countries. So they're responsible primarily for American public health implementation, but they also provide service to other countries. In addition, they work to coordinate disease outbreaks, reportable diseases from all of the 50 states and districts of the United States. So when you're looking for information on any particular disease or outbreak, no matter where in the country it's coming from, the CDC is often the first place to start. They don't have a lot of money to give out in grants, but they have a lot of resources that they share, and they collaborate with public health agencies and researchers on grants and research projects. Okay, so that's the national level. If your work is particularly meaningful to other countries or at the global level, you may want to go to the Global Forum for Health Research. That's what it says here. This screen is, I don't know if we're even able to shrink the screen, probably not. But so the Global Forum for Health Research, what is their vision? Anybody remember where they're located? Where is the Global Forum for Health Research? Geneva, Switzerland, right next to the World Health Organization. They may be in the same building. But what's their main reason for being? What do they see as a problem that they're trying to fix?
They deal with health problems in the poor, so the needy.
For the poor and the needy, and they frame it as an equity problem. What you associate the Global Forum for Health Research with is the 1090 equity problem. They have done research suggesting that 90% of all the resources available for health research is spent on diseases that affect 10% of the population, and that the diseases that affect 90% of the population, we only spend 10% of our resources. So they want to correct the 1090 equity issue in health. So they work primarily with developing countries or poor countries where the diseases are neglected because there's no opportunity to make a profit if you are working on drug development, for example. But they don't only just work with poor countries and developing countries. If you remember the presentation by the Allergan speaker, he talked about orphan diseases, so diseases that affect just a very small number of people, and it doesn't pay the pharmaceutical industry to put a lot of resources, research and development into drug discovery. The Global Forum for Health Research will support that kind of work, even if most of the people who suffer from the disease are in developed countries. So they're more interested in equity issues, regardless of where those issues arise in the world. Okay, so let's do a little bit more. What happens at the World Health Assembly? What is the World Health Assembly? This is a kind of day I should give credit for pop quiz, because half the class is in here. And those of you who are here should be motivated to get points. I probably will do that. So what's the World Health Assembly? You should roll off your tongue. Yeah.
Or just leaders from the world just get together and set an agenda for what problems they want to deal with?
The leaders, you said the leaders of
Health.
the ministers of health of every country, right? They come together under the guidance of the World Health Organization to determine the priorities for world health over the next year. So it is an annual assembly of representatives of the health sector of every country to set the agenda of the World Health Organization. all United Nations organizations are supported by member countries, and so those agencies under the United Nations have to cater to the issues and priorities that the member countries want to address. So this is the forum every year in May where the priorities are established. Okay? And who's the current director of the World Health Organization? Yes?
Dr.
Margaret Chan, yes. And where is she from originally? You don't know, okay.
Hong Kong.
Hong Kong, yeah. She was the Minister of Health for Hong Kong before Hong Kong transitioned to the British. And she did a lot of very important work there. And when we had the first pandemic flu, bird flu epidemic, if you remember, a lot of people thought that China did not respond very quickly and did not warn the other countries because they were trying to protect their market and tourists and such things. And so it was a big brouhaha with the World Health Organization, but Margaret Chan did a lot of work in Hong Kong to make sure that the epidemic was curtailed relatively quickly, and she laid an example that a lot of countries emulated, and I think she made her name through that process and was subsequently nominated and elected to become the director of the World Health Organization. She's in her second term, I believe, but this is always there's always a little bit of politics. But the first thing is to have the credentials, to have the training. So she's MD, MPH, and also to make yourself available for opportunities that might become more visible to those who do the nominations. Okay, what about the Robert Wood Johnson Foundation? What's their mission? What's their focus? You know?
Improving the health, like improving health problems and the health of everyone in America and around the world, and like the way it's delivered.
You said something that's not quite accurate. Improving the health of everyone in America and around the world, you said? Yeah, they're very focused on American healthcare. It's a very, very effective and influential organization, but their priorities are pretty much United States, and they have all kinds of funding available for training, for implementation of programs. And who's the president of the Robert Wood Johnson Foundation? Tell us. Yeah. I can't say it either, but she's also very, she had the credentials. She got her MD, I think, from Harvard Medical School, and worked for a long time, both in private practice and in government, and ultimately was nominated to serve in this role. But what Robert Wood Johnson Foundation does is to look, and they also have a process through which they set priorities for what the American burden of diseases and where they should focus their money. So if you were asked if you were asked to join their panel to establish the agenda for healthcare in the United States, what would be the priorities? Well, what are the biggest burden of diseases in the U.S.? What kills Americans most, or what makes us sick the most?
Cardiovascular disease.
Cardiovascular disease, she says. Diabetes, obesity. HIV. Does HIV kill us a lot? No. Used to, but maybe not. But it's in the public imagination, it's still a very big issue. Anything else? I mean, we showed some priorities for them, right? They're very much into health policy, right? It's kind of similar to the equity problem that the Global Forum for Health Research does. So we have a lot of equity problems in healthcare within the United States, like people who don't have health insurance in the most affluent country in the world. And the Affordable Care Act tried to change that, but you saw how long of a process that is and how controversial it is. And so Robert Wood Johnson Foundation is very much interested in those kinds of issues. But you didn't mention cancer. What happened this week about cancer? Was it yesterday, 2 days ago, that made this another point of debate in the US? Nothing in the news this week about cancer?
I heard was some celebrity named Angelina Jolie.
A celebrity named Angel. Yes, that's what I'm
Okay.
talking about. Who is she, by the way? Yeah.
No, I know who she is, but
I
I'm
know.
saying like this.
Yeah. So why is that? Why does that bring back the question about prevention and what we do for cancer?
Why did it bring back there?
Well, what was the debate? Maybe you just saw a news flash on TV.
Yeah.
She was high risk for breast cancer, so instead of waiting to get the disease, she just got rid of the
Right. So we in public health put a lot of energy and effort into screening, which is what we do for prevention, mostly for breast, because it's for all cancers actually, smoking and lung cancer, but we don't really understand how to prevent breast cancer. So what she has familial predisposition. Her mother had cancer, and she probably got tested for the gene for breast cancer. It's called the BRCA gene. But the genes don't say you will get cancer. It's a predisposition. There's a probability and statistics about it. And so what some women do is to make the difficult decision that rather than wait and find out, just go through mastectomy, which is also a life-changing outcome in many ways. And so it's been controversial for a while how we interpret genetic information to do prevention. If you're exposed to toxic chemicals and you have the genetic predisposition, you could do prevention by not taking jobs where you would be exposed. If they found a genetic predisposition to lung cancer, you choose not to work in asbestos mines. You choose not to smoke. And those are relatively easy lifestyle decisions. But with breast cancer, it's a very difficult intervention that I think the debate will continue on what we know about the genetics of cancers in general, what we know about the interaction between the genetics and the environment, and how we use that to formulate policy on frequency of screening and the intervention that may be less drastic than surgery. But cancers are not only in the public imagination a lot, but they're also a major cause of disease and disability in the United States. And the Robert Wood Johnson Foundation certainly works on that. So what would you consider the biggest difference between the Robert Wood Johnson Foundation and the Bill and Melinda Gates? What's the vision and priorities of the Gates Foundation in health?
The Gates Foundation deals a lot more with global health and like infectious diseases.
Yeah, very interested in global health issues. The things HIV/AIDS will be one of their concerns, for example, because that's more of a developing country problem in terms of its current rise. Things like tuberculosis, right? It's a huge problem internationally. Malaria, right? So you could name a few diseases where they're really very much interested, and they're interested in vaccination. Within the US, they are interested in health education. That's really their only domestic program, is to look at educational intervention. Okay, it's a good review. So we also talked a little bit about the NIH and some of the agencies that might fund the proposals that you're writing. But we then introduced some of the other kinds of agencies that might be of interest. The RWJ, the Gates Foundation, being some of those. Pharmaceutical companies like Allergan can fund research or program implementation. American Diabetes Association, and like the speaker today, their organization, the Alzheimer's Association, can also fund certain kinds of work. So we're not limiting your target to just the NIH, although I do believe you should know as much about the NIH as you can. But I'd like to hear from some of you, now that the draft is pretty much due tomorrow, what you've been thinking in terms of grant proposal, what agencies you're targeting, what your working title will be. Karen is not here today. She sent me an email that she has an excuse. Is Lydia here? Okay, there you are.
So I'm at the American Heart Association.
American Heart Association. Yes, we can see.
And so I'll be asking a grant from them because they do fund people. And so what I'm working on is the effect of a no-salt diet, restricting it entirely, and allowing 30 minutes of exercise 7 days a week, and trying to see the impact on that in adults, to see over a year-long period, to see if it does decrease their body mass index, cholesterol level, and blood pressure.
Okay. So she's planning to write a grant proposal and submit to the American Heart Association to look at, to investigate, and this is a research program, the restriction on dietary salt and exercise on health outcomes. Not heart attack per se, but the precursors to cardiovascular disease. So in writing such a proposal, it would be very important to focus, to think about the methodology. So it would have to be obvious in your proposal that you've thought about the sample size. How many people do you need to recruit to carry out such a project?
I'm thinking at least 1,000.
Why?
A larger sample size will give a better indication
Right.
of the entire population.
Okay, so she said she's thinking about 1,000 because a larger sample size will give a more reliable result. But what if I say 1,000 is too small or too big? I mean, how do you just, it's okay, you just said 1,000 because you think it's a large number, but it depends on what you're measuring, right? How do you find out the sample size for when you haven't yet done the study? Yeah? What did you say?
Margin of error.
Margin of error. Not really.
Isn't it called power calculation?
Power calculation. Is this ring a bell? So if you write such a proposal and you don't include such things in the proposal, you will not get points in the method section. So a power analysis is a statistical program. It's a statistical method where you say, here is the intervention, here's the outcome I'm looking at. The outcome, the incidence in the population is, you know, maybe 5 out of 1,000 people get high blood pressure if they're on diets with too high levels of sugar. And based on the possible outcomes and the numbers of outcomes, so you could have 1,000 people go through the process for a year and nobody gets high blood pressure because it's not long enough. But if you do 1 million people, you may be able to do that. Yeah, it also depends on whether you have different levels of, it's either yes salt, no salt, right? But you could have grades of salt intake. So if you just have 1,000 people who are not on sodium diet, you'd have to have a control population, right? Who are taking salt with their food, but they would vary in the amount of salt that they take. And so the comparison will essentially be those who are not taking salt and everybody else, but to be able to get a good sense of the outcome in terms of disease, you'd have to characterize the everybody else, the control group. Okay. So having a control group is very important. You'll get points for that. Having the methodological knowledge in terms of statistics, you'll get points for that in your study design. Understanding the incidence and prevalence of the disease you're trying to prevent in the population and including such epidemiological data is important. You'll get points for that as well. If you don't put any of those things, it will be a very bad proposal that has no chance of funding, so you will not get full points. Okay. You have any other questions about what you're... All right, so Devin, is Devin here? Okay, there you are.
Okay, I'm looking at obesity in children.
Mm-hmm.
And I kind of wanted to do a health policy implementation in schools, like better nutrition and just like more physical activity, but also do like an education program towards parents.
Okay. What agency are you thinking will be interested in funding this? Of all of them, I mean, there could be some NIH. NIH has a new program called PCORI, Patient Care Outcomes Research, which is exactly to support something like this. But the RWJ, the Robert Wood Johnson Foundation, is probably smaller, more manageable in terms of writing a proposal to them. But when you said you're going to look at policy implementation, that implies that there's already a policy in place that you want to see if it's implemented well, it will have an effect. But what would that policy be?
I want to limit the amount of like sodas in school or like sugary things.
Okay, but that, is there an existing policy about that? No.
Well,
I mean,
there's a lot of research that.
Let me put it this way. At what level is it? City policy, county policy, state policy, national policy? Costa Mesa School District has a policy? Huh? Okay, so it's okay. There are two different types of grant proposals with respect to policy. One is to say, okay, we already have a policy. Okay, so let's think about a policy that the state of New York started and California, I think, implemented, which is to say, when you go to a restaurant, the restaurants have to tell you how many calories, they have to print in their menu, how many calories each of the items are, right? So we didn't used to have that. Okay. Now, a public health person will come and say, well, this policy, clearly some restaurants were against it because it's expensive. They have to do more work and maybe consumers maybe their profit margin is already small, so, but the policy was implemented anyway. Now, a public health person will come and say, has it had an effect on the choices people make in terms of their diet? And if they've made those choices, has it had an effect on the health? Okay, so, because that's our goal, ultimately. So you could write a grant proposal to test whether such policies have actually made a difference. Okay. So that's an existing policy, no matter how controversial it is. And people do it all the time. You know, helmet laws come, don't text while you drive laws. Those are policies meant to protect people. But we almost always don't have the evidence ahead of time. We just think it's going to help. Somebody has to go there, get a grant, and study, did it help? Maybe after 5 years, 10 years or something. Because that's one kind. The other kind of policy research is to say, we don't currently have a policy on X. I'm going to show you all that if we had that policy, it will help. So you create a study very similar to the no salt in diet thing. Okay? And then you recruit people who will, so in this case, you might have 2 different schools, one with that policy, experimental policy, and the other one without. And then you follow them over 3-4 years, and then you measure whether or not there's been changes. The salt thing is interesting because there was a time the American Medical Association actually wanted restrictions on salt, but FDA said it's too complicated, they're not going to do it. Because the evidence is that if you cut salt out of diet, you'd actually have a lot of reduction in cardiovascular disease because people have done the studies. They've gone to get grants and studied these kinds of effects. So in this case, you do the experiment. And then when it works, you report to the Costa Mesa School District and say, look, I studied this school, that school, here are the differences, here's the outcome. If you made this policy for all the schools, we'll save. Okay. So that's experimental design, which is a very important part of all proposals, right? Hi, Deb. You're early. Yeah, you're. Please come on in. Okay. So we'll just finish a little bit here. Christiana. So, Devin, did you have any more? Or did you prefer Colleen? I don't know.
No,
Devin, okay. Any more questions? Okay. Christiana, please have a seat here. Thank you. Christiana, yes, hi.
So I'm at Vitality, and we do worksite wellness and health
Mm-hmm.
promotion. So what I was thinking about for the grant was, because the worksite wellness programs are actually pretty new, like in our society now, and there's not that much research on like low income, like how that affects the low income workplaces or like areas that are not as like developed, I guess.
Mm-hmm.
So my hopes is to conduct studies at smaller or like different type of corporations, because a lot of the workplaces now are just like the big corporations, so I just want like the smaller corporations and like particularly in like the lower income areas.
Okay, what agency are you thinking you might
I was thinking the
approach for this?
Heskey Foundation.
Heskey.
Heskey. So he's actually, it's the same person that started Kmart,
Mm-hmm.
and then their mission is to promote health and well-being of low-income and vulnerable populations, and I was thinking that could be a good.
Okay, so tell us your, I think you already did, but in a very concise way, the experimental design.
I think I'm planning on having a group that participants and the non-participants, and
Mhm.
looking at the differences in biometric measurements and like conducting like surveys too to see their perceptions on stuff, and as well as like ethnicity, job level, and stress and just.
So you also have to think about the sample size. Yeah? Okay, thank you. Wayne. Okay.
So was thinking of seeing reducing stress, how it would affect alleviating symptoms for ADHD in children.
Okay, you're thinking of reducing stress, or you pose it as a question, as a hypothesis.
Or how would I write
Yeah.
a hypothesis?
Yeah. So something such as if we reduce stress among children, the level of ADHD diagnosis will go down. Is that what you're thinking of? No?
Like the symptoms.
The symptoms, yeah. The symptoms of ADHD will what?
Go down.
Go down, okay. Well, was that accurate, the way you're thinking? Okay, that implies you would have to include in your proposal a way to measure stress. Well, first you have to think about the connection, because you'd have to have some background research literature suggesting that stress level is associated with the symptoms of ADHD. Okay? You'd have to show very clearly in your introductory section that the literature backs that up. Okay? And then methodologically, how do you measure stress? On what scale? What instrument do you use for that?
Can we use cortisol levels?
Okay, so your project will have to describe the methods for measuring cortisol. And for that, what do you take? Urine, saliva, blood? Urine, okay. So you'd have to have a lab to store it and to do the analysis. You don't have to run the lab yourself. There are many labs for profit labs where you can send samples. Okay, but that implies that you need all of these projects is human subjects, right? So you have to have institutional review board. So you have to write all of that in your method section. You have to at least acknowledge that you need to get institutional review board. And the level of review you need when you're collecting biological samples, okay, saliva, urine, blood, is very different from if you're doing a questionnaire. You're asking people questions. So you have to understand some of those differences and write it in your proposal. Okay, so, and then the outcome. How do you measure the symptoms of ADHD?
So I guess the degree of inattentiveness and...
But there are standardized surveys for doing this, right? So you have to reference them, not just make it up, because it's in the literature. And how will are you actually doing an experiment where you're applying different levels of stress to the kids? Or is it a natural experiment?
Like, I was thinking maybe of implementing a psychotherapy session or...
So you will have interventions that reduce stress in the experimentals and no intervention in the controls. Okay. Would they already all have the diagnosis of the symptoms? Okay. And then you'll follow them over time to see if the psychotherapy works. So this is very different from, so I know somebody who does a similar kind of research, but they use rats instead because it's easier to change things. So to stress rats, they just expose them to the scent of a fox, and you could do it for different periods of time, and then you measure the cortisol and all of those things. And you get very clean results. When you work with people, it's a very different, more challenging to get the outcome because of the variables that you can't possibly control. So especially if you're working within the diseased population. So they all have ADHD symptoms, and you want to know if this intervention will work against the background of those who don't receive that intervention. So sample size is important. You know, how big of an effect are you likely to see? So you'd have to do the same kind of power calculation. Okay? Yeah?
Yeah.
Good. Alexandra Rahel. Yeah, there you are.
I work at the American Cancer Society,
Mm-hmm.
and they don't focus on one specific cancer. They kind of
All of them.
board, which is kind of cool. My experiment is going to be like about thyroid cancer,
Mm-hmm.
because that's one of the highest cancers either developed after another cancer has already been diagnosed, or has the most mutations after being diagnosed. So they have a really hard time deciding what prevention methods.
What are the risk factors?
Like,
What risk factors for thyroid cancer? What usually leads to it?
That's what they don't know. So
Okay.
they connected that one gene may be
Mm-hmm.
connected to it. So I was going to take people with that gene and split them into two groups. One group just focusing all on nutrition and lifestyle choices like exercise, stuff like that. Other group, let them do what they usually do and see if either the nutrition and exercise helps or just makes it the same or worse, I guess.
Yeah. So before they looked for genes, and it's true for any disease, when an investigator, a researcher starts thinking, oh, there must be a gene for this, typically the evidence is that it runs in families, that there are certain clusters in certain families, so they kind of get the idea that maybe the gene is conserved in that population. So I would need to see in your literature review that you have such information. It may precede the gene identification, right? So, but you will also include the papers that found the gene. And then in this case, the statistics is even more important in terms of the frequency of occurrence of that allele and the number of people you'd have to recruit to demonstrate the effect of the intervention that you are seeking, which are behavioral in most cases, right?
Yeah.
Okay. So your method section would have to kind of be comprehensive in this regard. And it would be important to also show data, epidemiological data on the prevalence of thyroid cancer.
Yeah.
You probably already have that. And if there are different groups that have more or less,
Yeah.
women, men, ethnic categories, what age, things like that. That will also have to be reflected in your sampling scheme. Okay. All right? Very confident about this. Who else wants to go that is not here? Who's feeling nervous about their proposal? Okay. We'll do more. So the first draft is what's due. There's a second draft before the final version. So I'll bring up in the next week and the week after other names for people to share. And hopefully the discussion can always help those whose names are not on the list. But I think if we have a robust discussion, everybody benefits from that. Okay, without further ado, we'll come back and talk about all this, but we have a guest speaker. These are research ethics and things I talked to you about very briefly about the Institutional Review Board and things. Okay.
My name's Deborah OConnor, and I'm delighted to be here with you today. And I am actually the Vice President of Programs and Education for the Orange County chapter of the Alzheimer's Association. And I've been with them it'll be 14 years this summer. And I love it. I have never been bored a single day in my life. And we keep growing as an organization, as a national organization, and also as a chapter. And it's been very exciting. And I want to tell you all in public health that in my next life, I think I'd like to go for my master's in public health, because I love public health. It's a great field. But I have a master's degree in counseling. I'm a marriage and family therapist by training. I work for the association, and I have a part-time private practice in Orange. And I'm also a certified case manager. I mostly manage people, but I also get to see families every now and then, which is my favorite part of the work. So today I'm going to talk to you a little bit about the impact of Alzheimer's, the vision and the mission of the association as a national organization, our core values, the strategic goals, because I know that that's important to you that are going into public health, a little bit of the history, Alzheimer's disease, and our core services at the association, the core services that we deliver to families and professionals, and then what we do in Orange County. So this is, I hope this is, I wonder how I'm going to get that to play. How do you, this is just a small video clip about the statistics of Alzheimer's disease that I hope you'll find interesting, and I'm not sure it's going to work. Oh, there we go. There we go. Thank you. Is that loud enough? So anyway, the numbers are staggering, and when I think about what's going to happen in the future, we really need to focus on Alzheimer's disease. And I think that as an organization, we're doing a much better job. You know, when this organization started in the 80s, it just started with a handful of people that started a national chapter, and then it grew to over 70 chapters around the country. And each chapter was kind of doing their own thing. And they all had a helpline, and they'd have support groups, and they'd have some services for families, but we weren't very unified. So over the last several years, especially the last decade, we have become more cohesive as a national organization, where we have established some norms, and we have certain core services that all the chapters across the country receive, and then we have some guidelines that we've all agreed upon. And what's really wonderful about this organization is because it's so grassroots, that as we grew and became a national organization, the national office and the chapters work together. We still form committees and groups and in order to develop programs, in order to establish our strategic plan. For example, we're working on our strategic plan for fiscal year 15, 16, and 17, and we have a steering committee, and it's made up of chapter staff like myself. I'm on it, and it also has people that are on the national board. Some of them are executive directors from different chapters. So it's very collaborative, and it works really well, and the lead folks are usually someone who's been assigned from the national board as part of that committee, and then a national person that's like a vice president at the national level. For example, We have several different steering committees working on the strategic plan, and the one that I belong to is on care and support, because that's my focus. I'm in programs and education, so that's the area that I'm focused on. But it does affect over 5 million Americans. There are 82,000, more than 82,000 individuals in Orange County that have Alzheimer's disease, or they're at risk of developing it in the near future. What that means is they have symptoms, probably what's called mild cognitive impairment. We call it MCI, and many of them will progress to having a full-blown dementia of some sort. It's the 6th leading cause of death in adults over 65. 8 in 10 live in homes with 80% of that care provided by family members or friends. And this is what we deal with on our helpline. In Orange County, we took 12,000 calls last year, and we're growing. It's just the amount of support that's needed for these families is enormous. It's a long disease. It lasts from 3 to 20 years, and that means that families and the individual with the disease need support for a very long time. And especially after, in the early stages, people are pretty functional and they can do a lot for themselves, but as they progress into the more moderate stages of the disease, they really need a lot of supervision. They could be in perfect physical health. Blood pressure's great, they're active, they eat well, they don't have diabetes, no heart disease, none of those diseases, and yet they need a lot of supervision because they have poor judgment and they can't think for themselves and they forget. So,
is the death, are the deaths because of Alzheimer's per se, or because of the secondary effects, falling, injury, forgetting things?
I think that they have put those together, because I think that if they didn't have Alzheimer's, they would not have had those other kinds of issues. For example, in the later stages of the disease, many people have eating and swallowing problems, so if they aspirate and then they get to pneumonia and then they die, it used to be that they would classify them as a death from pneumonia, which is correct too. It's just we really needed to have that Alzheimer's disease in there, otherwise we can't track the impact of this disease on older adults, and so it skews the numbers. That was a great question, of course. So our vision is to have a world without Alzheimer's disease. We would like nothing more than to not have Alzheimer's disease. And I tell people, I would love to not have a job at the Alzheimer's Association, but it doesn't look like that's going to happen too soon. Our mission is to eliminate Alzheimer's disease through the advancement of research, to provide and enhance care and support to those who are affected by it, and to reduce the risk of dementia through the promotion of brain health. So that is really our focus, our mission, and everything sort of pivots around that. And I did want to let you know that the Alzheimer's Association is the world's leading voluntary health organization in Alzheimer's care, support, and research. We are the largest private funder of research in the country. So our core values, which is important, is integrity. We want to maintain transparency in our relationships with each other and our various constituents. We want a commitment to excellence. We want to lead through innovation. We want to lead the way. And we want to use technology. We want to increase knowledge. We're inclusive. We operate in a spirit of inclusiveness by providing opportunities for forums for our stakeholders. One example of this is that at the national level, we have an early stage advisory committee. It's made up of people in the early stages of the disease. And they provide us with feedback and information which help to drive our mission. So we want to hear from everyone. It's not that we decide. We don't decide by ourselves. We decide with our constituents and with each other from the chapters and national. Diversity. We encourage and welcome the power of diversity, especially those who have been underserved or underrepresented. So that's a big focus for us. And in fact, our next strategic plan, we're really going to focus on even more on diversity. That's one of our strategic priorities for this next cycle of strategic planning. Consumer focus, as I said, we want to learn, we want to meet their needs of these individuals and families and caregivers, and so we seek to understand them better and to get feedback and information from them. Accountability, we keep our commitments, we make measurable progress, we have outcomes for a lot of the programs that we have. We keep developing more and more evidence-based programs because what we want to deliver are things that actually change behavior and make a difference in people's lives. So this is our strategic priorities, and as I said, that I'm on the steering committee at the national level for this next strategic planning cycle, and I'm on the one that has to do with increasing concern and awareness. Then we also have growing revenue to meet our mission. Without funding, we really can't do the work that we need to do. And the Orange County chapter received about 1% of our funding or less came from federal or state funds. So everything else comes from our walks, from grants, foundations, and from the generosity of just people who have had our services and have benefited from that. So we also want to enhance care and support. Oh, I'm sorry, I said that wrong. Increasing concern and awareness is actually more global, and my area does overlap with that, but that's more about getting the word out. That's why we develop the facts and figures every year, and we release them. They're online in our website, and we want to be the leader in providing information about the disease and getting the word out. I still run into people all the time that say, I didn't even know that you existed. We have so many programs and services, and they've never tapped into them. Enhancing care and support, these are things like education programs for professionals, for families, early stage programs for people with the disease, support groups, care consultation where we meet with families to help them figure out what it is that they need to do and how to plan for the future and how to deal with their immediate issues. And then accelerating research. The research piece is really exciting because the Alzheimer's Association started an international conference where we invite hundreds of researchers to come together and share what it is that they're doing. And this used to occur every other year, and we have just changed that to every year. So this year it will be in Boston, and not as exciting as France, but nevertheless a great city, and it will run for about 5 to 6 days, and all these researchers come in and share their knowledge. And we do continue to fund research, and we've funded about 2,100 scientists across the country. And then we also want to advance public policy. We want our public officials to understand the importance of Alzheimer's disease and about putting resources into that and recognizing that as an issue. In the state of California, we actually have been involved in developing a state plan. And we have 5 chapters in California. And we actually, the 5 chapters got together and put together a public policy forum. And we hired somebody that sits at Sacramento and helps to direct the public policy and helps us with public policy for the entire state. So we were one of the first chapters to adopt that type of collaborative. And we also do that for programs and services. We have what's called program forums. So the vice presidents and education folks meet face-to-face once a quarter and once a month on a telephone conference call to discuss how we might develop education programs and roll them out across the state, or how we can do things smarter by not replicating. If each chapter's doing something different, why don't we work together and save some human resources and do a better job?
Sorry, I have a question.
Yes.
So you fund research, but you also apply for grants.
We
to
do.
Get your own funding. And one of the assignments in the classes, they have to write a proposal to either do research or implement a project.
Yes.
The distinction between 1% of your funds that you receive from federal and state money and the grants that you write.
Right.
Do you write grants to places like NIH to,
National does,
right,
but our local chapter does not, because there's a layer of administration that goes along with those kinds of grants that we don't have the staffing to manage that. However, the one, we've done something really interesting in Orange County. It's not just the association, but the Caregiver Resource Center that's in Brea, they would apply for these state grants, these Family Caregiver Support Program grants. And then we got some additional money from the Office on Aging because we said, you know what, we want to bring in some of the nonprofits in this in the community, and we want to look at how we can disseminate these funds so that we can get some additional needs met, not just by the Caregiver Resource Center, but many different organizations. So they did fund us, and it was under the supervision of the Office on Aging, and the fiscal agent for that is the Caregiver Resource Center. So that is where our little tiny pot of money comes from. That what we've done with it is we give out some respite for caregivers. We give out medic alert, safe return safety bracelets, identification bracelets, and it also helps to fund our a tiny piece of our helpline. So our helpline is a very expensive program to run because it's 24/7, but and I think our funding was less than $20,000 for the Family Caregiver Support Program, and we have a $3.2 million budget. So you can see that it's very small. So the rest of it comes from donors out in the community, and we have in recent gotten some very nice funds. Someone left us their estate, which will really help us to move things forward. We're putting, I think, $1 million, it's either $1 million or $2 million into research. And then National gets a portion of that. You know, we have something called shared fundraising, and it works very well for all of us because we get a lot from National, and so they need part of that funding. And it's been a good partnership with National and the local chapters. So what is dementia? I'm going to tell you a little bit about that. That is a global term, and there's a lot of confusion about what dementia is. Do all of you understand what dementia is? You know, these are cognitive changes that take place in a person, and it has to meet criteria in the criteria that lets them label that as a full-blown dementia. And so what happens is a person will have cognitive changes. A lot of that will be short-term memory or memory changes, and it has to be enough to meet that criteria. So you have people who do have significant cognitive changes, confusion, memory loss, declining problem solving, judgment skills, language problems, to be diagnosed with dementia. But then dementia, there are many different types of dementia. So you have to think of dementia as a big umbrella like cancer. Somebody was just talking about cancer earlier and wanted to focus on a particular type, thyroid. Well, you think about dementia is the big umbrella like cancer is, and underneath that are all the different types. So Alzheimer's disease is one type of dementia. So you hear it used interchangeably. Sometimes they'll say, and we have families that will say, well, my mother doesn't have a dementia, she has Alzheimer's, or my mother has Alzheimer's, she doesn't have dementia, you know, one of the two. So they get it confused. It may be reversible or irreversible. Alzheimer's disease is irreversible. So there you have mental deterioration, and then you have the different types. And it's a little bit of a misnomer when it says dementia-causing conditions that may be reversed, because they're really not a true dementia. It's like they're dementia-like. For example, a person that might have a severe depression may have slowing of memory and and slowing of thought process. And I had a 22-year-old that had ECT treatments, electric shock treatments for depression. And she came into me one day and she said, I'm sure I have Alzheimer's disease. And I said, well, honey, probably don't, but let's talk to your doctor about it. You've had these treatments and sometimes it impairs that. Plus she was still depressed, and so she had that slowing of memory, but it was scary for her. And once you treat the depression with medications, sometimes people will, improve. And then the hard part with Alzheimer's disease is sometimes when they have Alzheimer's disease, they also experience depression. And so then you don't know, is it depression that's impacting the memory, or is it the cognitive impairment that's creating the depression? Drug interactions can affect memory. A lot of chemotherapies for cancer, people have problems with their memory. Nutritional deficiencies, vitamin B, and people can get disoriented, and thyroid disease. So there are different things that might cause that cognitive decline. So it's really important to get an evaluation and to see a medical doctor about that and to get a full assessment. You know, I had a family member, I like to tell this story because it's so important to get an evaluation and an assessment. I had a friend of our family who called me and he said, Deb, you know, my mother-in-law is here from Arizona, and he lived in El Cajon in San Diego. And he said, we had a family reunion and the family is saying, my gosh, you have got to get your mother-in-law to the doctor. Her Alzheimer's is so bad now. And I said, well, Frank, has she been diagnosed? And he said, no, we can't get her to the doctor. I said, you gotta get her to the doctor. You have no idea what it is. And this had been going on for 3 years, right? Started out slow, but the husband didn't want to press her because she got agitated and didn't want to go to the doctor. So I quickly got on the phone and I got him in on a cancellation at the UC San Diego's assessment center, very similar to what they have here at UCI at the Mind Clinic. So I got them in on a cancellation. She got in there. Well, guess what? She doesn't have Alzheimer's. She has a big fat tumor. And now it was too late. There was nothing they could do. It was inoperable at that point. And there was something they could do about it earlier. So it was very tragic. So we can't assume that because someone has memory problems that it's Alzheimer's disease or old age. And wholesale memory loss is not part of normal aging. The slowing of the memory is, but wholesale memory loss is not. Any questions? So what is Alzheimer's? The most common irreversible type of dementia. Disease of the brain that causes problems with memory, thinking, and behavior. And I mentioned earlier, it lasts anywhere from 3 to 20 years. And the average lifespan after diagnosis is 8 years. Okay? I think early on, a lot of older adults, especially if it's a couple, when someone starts to have some memory problems, they kind of ignore it. Plus the other partner, they sort of build these the bond together where one sort of picks up for the shortages in the other, and so they can kind of function pretty well. And we always see an increase in phone calls from adult children after the holidays. They'll call us and say, oh my goodness, I went back to visit my mom and I was there for 4 days. So they don't pick it up on the short telephone conversation because it's short. But when they're there with their mom for 4 days, it's like, there's something really wrong. What should I do? So this is a picture of, yes?
You said the tumor, was that a brain tumor?
Yes, brain tumor. Thank you. Yeah, it was a big brain tumor. Yes?
So is it like standard procedures for physicians when working with patients over a certain age, like 65, like regular brain screenings?
Oh, like memory screens? Mm-hmm. Well, that is so progressive. Thank you. We would love for them to do that. And in fact, we have a huge movement in Orange County to do physician outreach. We're doing a ton of it right now. We're working with Kaiser. We're trying to get in on the ground, where patients come in. And we have begun to develop some tools for them. Well, actually, there are a lot of tools out there, but kind of putting together the toolkit for physicians to do memory screens and evaluations on people over a certain age. So that's what we're trying to do. And it's really tough though, because the daughter will bring the mom in and she's very social, has lovely social skills. So the daughter says to the doctor, well, the mother's not there, she's got memory problems and I don't know what to do. And the doctor has a conversation with her and she has perfect social skills, and he says, well, there's nothing wrong with your mother, she's fine. So it's really tough. You have to spend time with people. I mean, I did this with a family. I went out to see a daughter called, and I said, well, I'm going to come out and make a home visit. This was several years ago, and she said, don't bother, you'll be like everybody else that says there's nothing wrong with my mother. And I said, well, I'll tell you what, I'm going to stay for as long as it takes for me to see what you see. And she said, okay, fine. She had no confidence in it. So I went out to the home, I talked to her mom, lovely, beautiful social skills, told her she had a lovely house. She said, would you like a tour? I said, I would love to. We started in her backyard, looked at all her lemon and orange trees, went through the house. She told me about the pictures and who was who. Beautiful social skills. Get back to where we started, and I said, well, you just have a lovely home. And she said, would you like a tour? The daughter standing behind me going, yes, that's what I'm talking about. So I said, the good part for you is she will be a lovely person in a day program. She's very social and she's really sweet. I said, the hard part is that you're really going to have to talk to the doctor more, and we're going to have to do a little work there, because it's hard to get anybody to believe that unless they stay long enough. And everybody's dementia looks a little different. Sometimes you see people who have been beautiful personality, and then now they're just cantankerous, angry, belligerent, they think you're stealing, paranoid, lots of different symptoms like that. Sometimes you see people who have been cantankerous all their lives, and all of a sudden they're sweet, and this is a hard part too, because sometimes you have families, that child may have experienced child abuse from their parent when they were younger, because they were pretty nasty, right? Over disciplinarian, and now here they are, sweet and helpless, and they're supposed to take care of them. So there's a lot of those mixed feelings. So it's helpful to get some counseling when they're in that position. Any other questions?
Sorry, there is one.
Go ahead.
Before you came in, we talked about breast cancer and the screening and the age at which people have to. Is there a similar policy for screening? I mean, the video said it's not preventable.
Right.
And people may not want to know, but what's the current policy in terms of when to start, even when you don't have symptoms?
Yeah, I don't know if it's an exact policy, but I would say we like to start at between 60 and 65, right in there, starting to take a look at that, and here's another issue with looking at memory. You may have an older adult who's 85 years old, and you go to make a home visit with them and ask them what day it is, what time it is, what's the day, the date, things like that. They might get some of them, but not others, because they don't work anymore. For us, what day it is and the date is a pretty important thing, because we have places we have to be and commitments. But when you don't have commitments, so you have to be thoughtful about how you do your assessments and evaluations with those folks. We are diagnosing more and more of early onset Alzheimer's disease and other variants such as Lewy body and FTD, frontal temporal dementia, in younger folks. And their symptoms are a little bit different, and some of the challenges are even greater with the frontal temporal dementia, because that's where all your judgment and social is. And so sometimes what we see is antisocial behavior. And sometimes that's what families see first. For example, we had one woman who had teenage children, and the dad was flirting inappropriately with her friends. And they just thought that he was going through a midlife crisis, and what's wrong with him? He started to have affairs. Well, it turns out he had frontal temporal dementia, and that was the first sign of it. And the memory is secondary to the antisocial behavior. But very, very stressful for families, and stressful because most of those folks with FTD do not have the ability to observe themselves. So they basically think that they're fine and there's nothing wrong with them, and so it's everyone else's problem. And then even some people with dementia have that. A lot of them do. My daughter's got the problem, I'm fine. So we have to be really creative, and you have to always remember that people with dementia are frightened. It's very, very frightening disease, and when people get afraid, sometimes that's a normal response, to get angry, when you're afraid, and to be defensive. So this is a picture of plaques and tangles. Let me see, I think there's is this the, yeah. So what you see is this out here, these are plaques, and the plaques are outside, and the tangles are actually inside the cell. But both of these things are the hallmark of Alzheimer's disease, plaques and tangles. And they interfere with the cell's ability to communicate and to take in basically nutrients. I mean, you know that from your biology. That's a very simplistic way of saying it, but what happens is they can't take in nutrients and the cells eventually die, and so whatever function that they served then goes away. And so we usually see that people have more damage in the hippocampus area, which is right around here, and that's where short-term memory is. So here's a beautiful picture. I love these. I love diagnostics because you look at it from different ways. We just had a picture of a cellular level, right? So you look at brain tissue and it's got plaques and tangles. And then you look at this beautiful PET scan that looks at metabolic activity in the brain, and you see it's lit up like a Christmas tree on the normal brain, which means the neurons are firing and things are looking really good. And then you look at someone with Alzheimer's disease and you see all the cool colors. So it's not firing, it's not metabolizing, and we have problems with functioning. And then you look at here, well, this is actually just a slice, but this is more structural. So what do you see structurally in the brain? You see a nice plump brain on the left side, and you see one that has atrophy on the right. Enlarged ventricles, the cortex is shriveling, especially near the hippocampus where the short-term memory is. So I think a great way to diagnose is to have, MRI and PET scan, and so that you're looking at more than one thing to see what it is. So the 10 warning signs, memory changes that disrupt daily life. So this isn't, where did I put my keys? And then you're able to retrace your steps to find them. It's more about wholesale forgetting. People, they can't retrace their steps, and they completely forget, and it doesn't come back even with hints. For us, we get a few hints and we go, oh yes, yes, I remember that. I mean, that happens to me all the time. It's sad. Can't remember the name of a movie I just saw. It's like, oh, darn it. As soon as someone says it, I'll say, that's the one I saw. That's not memory loss. That's not dementia. Challenges in planning and solving problems. Sometimes people will play card games. That's what one caregiver told me is they would play this card game, every week, and all of a sudden his wife started asking about the rules. She was forgetting the rules. She needed to be reminded. Now that's different than you haven't played for 6 months, or you haven't played for 6 weeks, and you go, now, is it the 4 that does that, or the 8? That's different. Difficulty completing familiar tasks, you see this sometimes, especially with problem solving with cooking. We had one of ours that cooked Thanksgiving dinner and forgot mashed potatoes. That's a pretty, American tradition, right? Potatoes and gravy, and forgot them. Confusion about time and place, not knowing what day it is or where they are. Their appointments, they start missing appointments or show up at the doctor's office on the wrong day. Now that can happen to any of us, but what you see is, you see that, and then you see other kinds of things, and you think, there's something going on here. Trouble with visual images and spatial relationships. Sometimes they don't see color contrast as well. Or visual images, they have problems. Especially in the moderate stages, these folks, they're afraid of the water in the shower, so they have a hard time bathing, or showering, I should say. Misplacing things and losing the ability to retrace steps. Decreased in poor judgment. We've had people, one of our clients was sold by the same salesman 3 king-size beds. So they're very vulnerable, and Orange County, we're really fortunate. We have the Orange County FAST, that's the Fiduciary Abuse Specialist Team, where nonprofit folks, social workers, Adult Protective Services, the District Attorney's Office, all kinds of experts come to this meeting on a monthly basis to discuss situations out in the community. So when they come, usually they come through the door of Adult Protective Services. For example, if we have an issue, we call Adult Protective Services, and they go out, and if it needs to come to the Fiduciary Abuse Specialist Team, it comes through APS to them.
Sorry, that means legal stuff? So
yes.
Prosecute people who take advantage of
right. And most of it, though, most of the elder abuse is done by families, people who are close to them. I know we think it's strangers, and sometimes we like to think it's strangers because it's hard to believe that it's really family members, but it is very often family members. And once they get a hold of all that money and they spend it, and it's really sad because then this person that could have been in a nice facility to live out her life ends up in a Medi-Cal facility, and that's not very nice. And once they've spent the money, it's really, even if you prosecute them, you can't change it. You can't get the money back so that they can care for themselves. Withdraw from social work and social activities, and some people are pretty good at hiding and masking. They don't remember a person's name and they'll call them honey, or, oh, it's so nice to see you, sweetie. They just don't say the name. And then there are others that can't track the conversation that's going on, and so they just become more and more quiet, and they just step out into the background because they feel insecure. And sometimes they just want to be in their own familiar environment later on in the disease because they feel safer there, and they can't negotiate change. It's really hard for them with change. Changes in mood and personality, I think I talked about that. Cantankerous, now sweet, sweet, now cantankerous, and just a whole continuum of different types of behaviors that you can see. So we'll hear from Joyce. I think I need to press it here, huh? So it's really sad. It doesn't discriminate. I think that there is a protective effect for people who receive more education because you have more neuron connections, and so I think that's somewhat protective. But the greatest risk factor for Alzheimer's disease is age. So I know some people are afraid of genetics and some things that are familial. For example, if it runs in your family. And your risk is higher if it runs in your family, but it does not mean that you will have Alzheimer's disease. There's less than 4% of the cases of Alzheimer's are truly genetic linked, meaning you have the gene, and if you will have Alzheimer's disease at some point in your life. And it's usually early onset. Now we're going to hear from Steve, and I just want you to get a feel for. And I also want to tell you that these folks are pretty amazing because they actually have the capacity to think about themselves and think about what they struggle with and then to communicate with you in a non-defensive way. But there are others who are in the same stage that they are that are not going to address anything with you because every person is different.
So that's very interesting to me because the range of how long people live with it, I think in one of the slides, 3 to 20 years.
Yes.
Typically by 8 years, a lot of people do die. But so I was thinking that that woman was recently diagnosed. But you're saying that some people could be that recent and still
live for
not
20.
able to communicate. Yeah, that somebody could live with it for 20 years and still be as coherent as that?
No,
okay.
no. I'm mainly, thank you for bringing that up. I'm mainly talking about how they are in the early stages. We have other folks, we have early stage programs, and one of the criteria for it is that they need to be able to talk about their process and what's happening. Otherwise, there's no benefit to them. Sometimes the family wants them to go through it because they want mom to understand she has a problem. And it really doesn't work. All it does is damage their self-esteem. I mean, they feel so wounded by it. They're so incredibly defensive that they're not appropriate for our early stage group. Now, if they have a little bit of denial, that's fine because most of them have some of that when they come in. It's protective and it's normal. They should have some. But that's what you'll see the differences in the early and the moderate stage. I've had moderate stage people that barely can talk, and they go, they'll give you this distressed look like there's something wrong with there's something wrong. And so they still are able to say that. And there's others that are cantankerous, get away from me, don't touch me, get out of here, I don't need any help from you, when they clearly need help. So you just get all of it, and we don't know who's going to do what. You can see that some people who have been fiercely independent in their life, and they don't like to depend on anyone, and they've been able to manage things, and they're pretty controlling, that personality, they tend not to do as well. They don't want to feel those vulnerable feelings. But that doesn't mean everybody that's been controlling in their life and fiercely independent will behave that way once they have the disease. So I think some of the damage depends on where the damage is in the brain, that it actually might impact their ability to have, to reflect upon themselves. You know, they don't have an observing ego, they can't observe. So. Where is that? There it is.
The types of things I noticed had to do with organizational abilities, mental abilities, and I was getting confused. I was finding it hard to plan, and there were two pivotal sort of moments that really brought this home to me. The first one happened when I went into work one morning and sat down at my desk to plan out my day and couldn't figure out what to do. And literally sat there for an hour frozen and could not figure out what piece of paper to pick up first.
Can you imagine how frightening that would be? Not for a minute, but for an hour. It's pretty frightening. He's so articulate, though. I love him. He's great. So I'm going to talk a little bit about what we do, and these are actually the core services that are offered at every chapter throughout the country, and that's our 24/7 helpline, and it's both. We have both local and national coverage, and chapters do it different ways. For example, almost all the chapters. Or many of the chapters will take their calls during the day, and then at night, our national office, they route to the national office and they take the calls. And then there were a few of us. We developed some criteria and a plan for the national office to begin taking those local calls even during the day for certain chapters. Some chapters have less resources than others, so it was really good for them because they didn't have enough support. And then for others like ours, we're growing, and so I'm thinking about the avalanche that's coming and how are we going to manage that. So I was part of that committee to develop the guidelines for how National would take our calls, because I believe in, you know, some folks are resistant and they say, well, I'm not going to change. And I always say, oh, let's bring on the change. Let me get in on the ground level so that I can have an impact on how it rolls out. So I'd rather see, I guess I'm one of those controlling ones. But anyway, so that's what we did, and we didn't have National take our daytime calls for the first year because I wanted them to work out the bugs, because we at Orange County, your Orange County chapter has one of the 5 top helplines in the country. We have incredible service at our helpline. And I didn't want to sacrifice any of that quality, you know, for quantity. So we did start in our second year, and now we're into our second year of having National take the calls, and it's actually worked out really well. What's ended up happening is we get reports from them in real time of who they've talked to and what they've said to them and what they've provided. So if there's anything that's missing from there, and we know most of these people, but if there's anything missing or we feel like we could give them additional resources, we will either email them immediately or call them back right away to give them that information. Our chapter holds what we call case review every single morning for 2 hours to go over every single call that has to come into our office the day before through National and locally, to make sure that we are doing everything that we can for each of these families. Because it's not, and we love numbers, you know, because everybody likes to grow and wants to perform, but every one of those numbers is a family. It's a real live human being, and they need our help. And we never want to forget that. We want to have the empathy and the compassion and provide that care and support at our local chapter. So we're pretty proud of it. We've got an LCSW that does case review every morning with the helpline, and we have an MSW on the helpline. I have a person who actually does all the technology piece for the helpline, meaning they input all the educational information on the web for us. They update all of our resources that we give out to families and update our national database with resources so that National has the same seamless resources that we do. So it's worked out really well, and as a matter of fact, we find that some of our families get double duty care because if we have time, we will then call them up and follow up to make sure that they don't need something else. And as you know, caregivers might call you and they have issues and they have things that they want to discuss with you, but they can only take in just so much at one time. So it's often really helpful to call them back in a week or two when they've had a chance to digest what they've been given and their situation, to then see how well they've done at following through with some of the recommendations and whether or not they need additional support. So it's worked out really well for us. Then we do care consultation, and in the early days when I first came there, we used to just make home visits. And I could see that we were going to drown because I did about 22 to 28 home visits a month on top of being in charge of all the programs in education. So it was a pretty tough job, and we had another social worker that was doing the same. I said, we're going to have to think differently about this. So we talked to some of our other partners like the Caregiver Resource Center, and we also talked to APS. When we get a call from a family, we might want to go out and make a home visit, but it's an APS call. They have to make a home visit within 10 days. It's mandatory for them. So why would they make a home visit and then we make a home visit? I said, why don't we start working smarter? We do less home visits, do as much as we can over the phone, and if you have to make a home visit or you feel that it's necessary, then that's okay. For example, we had a 91-year-old and we just could tell that she just couldn't take it in, and it wasn't APS and it wasn't a Caregiver Resource Center referral. So it was next to, she lived down the street from one of our helpline folks, and so she made a home visit just to check on her and see how well she was functioning in her environment. You don't get quite as much when you do it over the phone, but it is effective and it works very well, and sometimes for families, especially adult children, it works even better because they don't have that kind of time. We also, which I'm really grateful for, sometimes you have families and there's 6 siblings and they live in different parts of the country. So we can conference call all those family members in so that we get everybody on the same page. We link these family members who live in other parts of the country up to their local chapter for services and support and education, and then we develop a care plan for those families and how they'll move forward. And then each family member can decide what things that they can do to help with the situation. We have support groups for caregivers and people with the disease. We have the early stage. It's a psychoeducational model. It's 8 weeks. So that means it's part education and then it's part process or support. And we've been doing that for about 15 years. And they used to be 12 weeks, and then we tried a 10-week model, and then an 8-week. We settled in on 8 weeks. What we found is it didn't really matter if we had it for 12 weeks or 8 weeks. They would always get to the end and say it wasn't enough. So we had to look at it in terms of what do we need to deliver to them. During this period of time, one of our goals is that they begin to make friends and that they bond with one another because their lives are changing. Many times these folks that have been playing cards together and doing things with other friends, they start to drop out, and so their world gets smaller. So it's completely opposite of what you would do in an actual therapy group. In a therapy group, you wouldn't want them to get together outside because it dilutes the therapy, but it's not a therapy group. And one of our goals is to have them bond and socialize. And then,
is that
yes.
one-time event, or can they do 8 weeks this year and then?
Well, the 8-week part is a one-time, but what we also created is twice a month they have what's called continuation group. So once they graduate, they're invited to come to continuation group. And then just recently this year, and not all the chapters have this, what I'm talking about, we started something called Connect to Culture and More. And part of that is we replicated an evidence-based program called Meet Me at MoMA. And it was started at in New York at the Museum of Modern Art, and with the support of the Alzheimer's Association, both the national and the New York City chapter. And they started this program where they go into the museum, and person with dementia, they have a small group, they sit in chairs and they view like several pieces of art, maybe up to 5, and they talk about the paintings and about what they mean to them. And what's really interesting is it's hard to tell. Sometimes in the ones that we do here, we have a program called Meet Me at the Bowers Museum in Santa Ana. And caregivers and persons with dementia come to ours, and you can't tell which folks have dementia and which ones are the caregivers, because it's about their experience. It's about what it brings up to them. It's about the color that they like or the memory it stimulates. It's not about recent memory, so you really can't tell. I was there one day and I said, which one has dementia? I said, you can't tell. And so it's a very heartwarming program. Yes?
Are all these services mainly for the people in early stage, or was that only for the stakeholder meetings?
Well, the Meet Me at MoMA, that program, and Connect to Culture is mostly, we started it for early stage, but we have some moderate stage people in there. If somebody wants to come, we're not going to say no if they want to come. Now, all of these programs, are you talking about all of these programs? Yeah, and I got off a little bit because what I wanted to show you is these are the core services that are with all the chapters in the country. The Meet Me at the Bowers, they have Meet Me at MoMA in New York, and we have Meet Me at Bowers in Orange County, but not all the chapters have that program. But yes, everyone has these particular programs, and almost all chapters, actually every chapter has some form of early stage programming because it's one of our strategic priorities. Okay, does that answer it or not quite? You still have a question mark.
Support group, that's for...
It's for caregivers and for people with dementia.
So all these are also for, you can enroll in any stage for it. So I guess, yeah.
Okay, let me explain.
I guess when you finish explaining, maybe that'll answer my question.
Yeah, but I was thinking that people who are advanced, it might even be hard to get them out of their house. I mean,
yeah. Well, what we started, maybe I'll go to the next slide. Let me finish here, and then I'm going to go to the next slide, and I think it will be, it'll clear itself up. Everyone in the country has caregiver support groups, and every one of them has some sort of early stage activity. Everyone offers education. Everyone has a public policy and advocacy, and all chapters have safety services, okay? And now I think I'm going to clear this up. So now I'm talking about the early stage services, education, cultural, and social. 8-week supportive educational groups, and we have them in 3 places in the county so they don't have to travel so far. Then they have ongoing monthly support where they can come in twice a month, but they have to have graduated from the 8-week group. And then they are welcome to come to Connect to Culture and More. These are social and cultural activities. They took the train to San Juan Capistrano 2 weeks ago. So we continue to engage them in social and cultural activities, and we get feedback from them. In fact, some of our caregivers have formed a group, it's called Dare to Dream, from the early stage, and we're going to be meeting with them on a regular basis to talk about what it is that they need and what they're looking for. And we also have an art program called Memories in the Making, and it was actually developed here at the Orange County chapter, and it's a painting experience actually, and it's not about the art itself, meaning it doesn't matter what the art looks like to us. It's about their process. It's all process oriented, and it's about their memory and what it means to them. It just so happens that so much of the art is beautiful, and we have framers all over Orange County that donate framing to us. And then we have a collection of about 40 to 45 pieces every year, and we auction them off. The families have the first right to purchase them, and then if they don't, they want to donate it back to the association, then we sell the artwork. And we also have an artist tea for the persons with dementia and their families to come, and we recognize them for the lovely work that they've done. And what we do is mainly train people to deliver this program in facilities all over Orange County. We don't actually regularly deliver the painting classes, but what we do is train other people to deliver them out in the community. And then we have also volunteer opportunities for people with the disease. Does that help a little bit?
Yeah.
Okay. Any questions about that? Yes.
I just have a question about like the demographics of the clients that you tend to get. So I noticed that you do have the hotline and it's available in other languages as well, like Vietnamese and Korean. So do you get a lot of those kind of people come to you as well for services, like the Vietnamese?
We mostly go to the Latino and the Vietnamese population, even the Korean. We need to go to them. They don't actually come to us for the most part. We have a really robust Latino program, Latina, and we educate about 500 a month, and it's very robust. They have big support group, very different. Cultural groups do support groups in a different way. Most of the support groups, they like to keep the numbers down so that they have time to process. Latino, you know, they might have 30, and if it's a holiday, they could have 45 to 50 people there. They bring all the kids, they bring the people with dementia. We have a separate place and have activities for their family members and the children too. I mean, it's really nice, it's lovely. It's just very different. You know, and I come from a kind of traditional therapist background, so when we first started doing this, I thought, oh, we're not supposed to have it like this. You know, I was trying to, I had my rules, right? And then I thought, no, this is a whole different thing, and I need to loosen up mine. So I have the most amazing multicultural coordinator for Spanish. She is an angel, and she is gifted, and I listen to her. I ask her, Normita, what should we do here? She tells me, and I follow her because she knows her population, and she's incredibly successful, and they love her. They call her Saint Norma too. Yeah. Good question. Anybody else? Okay, let's listen to this one. This is a caregiver talking about her husband's experience, but this is also early stage.
Bill had been a graduate student in the Culminating degree, and he found himself having difficulty defending his thesis the last thing that he needed to do. He started making mistakes at work. We both somehow knew before he was diagnosed that something was very wrong. At first, we hoped it was something that they could either operate or cut out or burn out or something, or maybe he was depressed. Maybe he just needed a nice weekend and it would be fine. And then we realized maybe something was really very wrong. And it was. We went through several doctors, several unsuccessful attempts at getting some sort of diagnosis. Each time they would test Bill, he would ace their tests. If they wanted him to count backwards by 3, he could count backwards by 3.25. His problems were very, very subtle. And when we finally realized he was laid off from work, and I'm sure that was part of the reason why he was laid off from work. But during the election, when we elected a brand new president, although Bill wasn't working, he wanted to be active. So he volunteered to work at the polls. He was an officer of the election. And before he left, we were very, very excited about it. It was a long day. It was 5 o'clock in the morning. And we knew no matter what happened, it was going to be a historical event. So we were very, very excited. We would either have a female vice president or an African-American president. One of the two, and it was going to be huge. So we were excited about it. He went off, worked at the polls, came home and told me, and we were very animated, talked about the people all the way around the block waiting to vote, and we were so excited. We stayed up and watched the acceptance speeches, and we found out he won. We thought that was just amazing, and it was history. So the next morning, we got out and Bill said, I got to get the paper. I said, why? He said, I got to see who won. And we both realized, he lost the whole day before because it was such a long day. And that was when I realized how serious it really was.
And those are the folks that come to us in the early stages. are families like that. And we even have people in the early stage program that have MCI. So because they're still struggling and their issues are similar, even though they may not have been diagnosed with a full-blown dementia.
When you call Kitty caregiver, you meant she's a family member who gives care, not that she's a professional.
No, she's a family member. We call them caregivers, yeah, or care partners.
Yeah.
You know, in the early stages, we tend to call them care partners because it's offensive for the person with mild, memory issues to say he needs a caregiver. It's like, I don't really need a caregiver. So we're a little more careful with early stage folks, and they're not really caregivers. They're more care partners. So, and this is more about what we do here. And actually, we have over 50 support groups in Orange County, all over. Some of them are faith-based, others are in community centers. Some are for adult children. We have one men's group, soon to have another, very successful men's group. And and we have English, Spanish, Vietnamese, and Korean. We have a FTD Lewy body group, and this is a collaborative that we do with UCI, the Mind Institute, and we have two of them. One meets here on campus or over by Mind once a month, and the other one meets once a month in Irvine at our office. The reason why we have that as separate is because these folks have some really interesting issues that are different than many. Most of these folks, especially the FTD, tend to be younger, and they have all those behavioral issues. And so, the grief and the difficulty it's so intense. You can practically cut it with a knife in that group. It's just really, it's very intense. And it's not quite like that in a caregiver group where they predominantly have, older age onset Alzheimer's disease. Men's group. And we also had a bereavement group, although it's on hiatus right now. We haven't had anyone that was interested in coming. And then we started something called Breakfast Club. And this is where we really had to stop and think. We had folks that were in our early stage group and then in continuation. And at some point, they become month after month, they progress in the disease and they become moderate stage. And we realized that the folks that were newly the new folks coming out that had early stage Alzheimer's that were coming out of the 8-week groups and being moved into the continuation, they would come once and wouldn't come back. And it's because the folks that were in the continuation were progressing in place, and it was too scary for them. It was like a mirror for them. Oh my gosh, am I going to be there? So this has happened twice because it's really hard to ask someone to go. That they need to be in a different program. And we actually didn't have somewhere for them to go. We were hoping that when they were ready to move that they would go to day program. But some of them aren't ready for the day program, and some of them will never be ready for day program. So we said we need to start something new. So we started something called the Breakfast Club. And that is for moderate stage, and it's an activity-based group. The caregiver and the person with dementia come, and they do activities together. There's no we're going to learn something about Alzheimer's disease today or processing feelings about Alzheimer's disease and where they are. It's purely fun activities. We have one of our students, I think he might be from your department, and he comes in and he plays guitar, so he comes in and plays guitar for them. It's fantastic. They love it. They love him. He's cute too. And so that was a great solution, and now when people come into early stage, we tell the caregivers right away that when they start to progress that we're going to want to move them out of this and then into Breakfast Club, and then they have the other social activities as well. So
one of the things we discuss are cross-cutting themes in public health, and this slide shows a lot of that. So the cultural sensitivity by looking at the different ethnicities, I think that's great. We also talked about gender, and you have a men's group, and I assume that because women live longer than men, that most of the people who seek your services will be women. And I was wondering why specifically a men's group and not a women's group. So maybe two questions in that. Is it true that
Yeah.
there are more women, and what's...
Well, most of the groups are heavily weighted with females, the caregiver groups in general. I mean, and so they have fewer men, and so they tend to be outnumbered, and not all men, but they tend to think about things different at times. I hate to make generalities like that because it's just not fair, but we had a lot of feedback from a lot of men. They say, you know, I don't want to be in there and listen to all that. You know, it's too much for me, too many feelings, right? So, but then I just did a group the other day, and there were 3 men in it and 3 women, and these men were tearful, and they were appropriate, and they were amazing, actually, really incredible human beings. So if they're comfortable there, great, but we started the men's group for those that weren't comfortable. And we have some older guys that have never been to a support group, and they're like, the therapy, you know, that's like, you know, I don't need that. And so we say, well, it's the men, they get together, and they just, you know, we talk about it different. Okay, I'll come. It's all men, right? It's like the men's group. And so then they would come. So it's worked out really well. They're very bonded, and one of the caregivers is actually a facilitator now. He co-facilitates with one of our board members started that group. It has anywhere from 8 to 16 people in it every month. It's been really successful. So, and they all take turns bringing refreshments, and you know, they actually do similar things to the other caregiver groups, but it's okay. It's wherever people feel comfortable, and so we're trying to, you know, it's tough because you want to say issues are similar, you don't really need to separate or segregate people, but then on the other hand, you know, you're trying to meet their need as well, so it's difficult. Yep.
Are there any cases of early stage dementia that never progresses, or does it always get worse?
Generally speaking, they progress, but there are, I don't know if it's truly Alzheimer's disease. We did have someone years ago, and she got to a certain point. Her name was Jan. She started Alzheimer's International, DASN, and she lives in another part of the country, but she has never really progressed past a certain point. So one might say, well, maybe that she really doesn't have Alzheimer's disease. So it's a good question, and I'm not sure, because Alzheimer's disease, the way it's defined now, is a progressive disorder, and it is fatal. So that's the definition of it. And you know, we have all these different types of dementia. They used to call it senile dementia. She's senile, and you know, science is so wonderful, and we're so much better at differentiating different types of dementias and conditions. And my guess is it will continue to do that. And there are some brains, when they look at them, and they have lots of plaques and tangles, but people don't have outward cognitive impairment. And others who have just moderate and are severely impacted. And we don't know those things yet. You know, and there's a study right now, I'll just share this with you because it's so interesting to me. And he's kind of a friend of the association. He's up at UCLA, and he's doing a study where he's looking at the digits, and like this, the second and fourth digits, the ratio between them has something to do with the introduction of androgens in development, and that impacts the ratio, and that there's a slight increase in females, partly because they live longer, but also when they take transgenic mice, and they're male transgenic mice, and they introduce estrogen, they develop Alzheimer's disease more often. So it might be that there's something to that, and so they're looking at this digit study. So I have everybody in our office running around, putting their hand on the copy machine, and we take pictures of it, and there's no, there's no consent for it because there's no private information. It's just, you know, whether you're male or female, whether you have a diagnosis of Alzheimer's disease, and what your age is. But it's kind of fun, isn't it? Who knows what will happen? So we have lots of education. We actually did 480 7 educational programs last year in Orange County, and we educated, our attendance level was 24,449. So we were the top educator in the country, all the chapters. So we did a good job. We love education, it's important, and we do all kinds of things, basics, healthy living, understanding communication and behaviors, because that's a really tough thing for family caregivers. And we do legal workshops because we want people to plan early to get their all their papers in order, and all of that taken care of early on. Building a care partnership, this is actually addressing elder abuse, but it's a soft way. It's talking about having empathy for the caregiver and how to communicate properly with one another. So it takes all that sting and stigma out of that whole elder abuse issue, but we are educating families about what to look for and how to manage. And research conference we have once a year. That's a collaborative that we do with UCI's Mind. And we have lecture series as well. So we have family education. We have living with Alzheimer's, early, middle, and late stage programs. The Savvy Caregiver, this is an evidence-based program that was developed by someone that lives in another part of the country, and he has made it available. He said, as long as people get trained, it's available for you to use. So our California State chapter said, we're going to go for that. We brought him out to do a training for key people in the 5 chapters, and we've been doing it for about 4 or 5 years now. And it's been very well accepted, and then we actually hired somebody that, as a university professor in Texas, who took the Savvy Caregiver and transformed it into Spanish. So Savvy Caregiver is 6 sessions plus 1, and Cuidando is 2 4-hour segments. It's a completely different format because that 6-week thing doesn't tend to work with the Hispanic population. So, and it's been very successful and extremely helpful for caregivers. This program is about helping caregivers cope better and teaching them behaviors and giving them tools for self-care and the care of their loved one. It's to help change behavior, and we did get a state grant for that, and we did a 3-year research project to look at the outcomes of that program. We have free e-learning classes, Know the 10 Signs, the basics, legals. All of these are available for families. They can go online and they can take those for free. Professionals can do that as well. And we want people to go online, and we want them to use all of our resources. We have specialized portals for Asian, Hispanic, and we also have an African American portal. And we have kids and teens, and then another portal for other types of dementias. And this is something new in the last year and a half. It's the Caregiver Center. It's online, and it is, if there isn't anything else you go to look at, please go look at this. It's awesome. It has so much information, and caregivers can access it at any time. They have this Alzheimer's Navigator is like getting a care consultation, but doing it online. And the Caregiver Notebook, where they have just lots of information. There's a stress checklist. They can take all the training programs, and the care team calendar. It's really wonderful. Whole families, maybe there's 6 people in the family, mom has a doctor appointment, everybody's signed up on the calendar, an email goes out, can anybody take mom to the doctor on Tuesday? And then they all respond, and they all have access to the same calendar that's about managing mom's care. Really, really helpful for adult children to manage the care. And I just met with some care managers from Silverado Senior Living last week, and they're going to use this in their care management with their families. I said, it's free and we have it. I want you to pilot this and tell me how it works for you as a professional. I want people to use the tools that are available. So we also have professional education. This is evidence-based. We have CARES, and it's through Essentials on our website, and there is a fee. The services for families are free, but the services for professional education have, many of them have a fee attached to them, but not all. And they have many topics to help improve the quality of care for people with Alzheimer's disease. They're free, I said that. And any questions? Thank you.
I know we've been asking questions all along.
I love questions.
So for the professional training that you charge for, so if somebody gets a bachelor's degree in public health care and they want to take, what do they get at the end of it? Is it a certificate?
It's a certification.
That they can
Yeah.
now work with Alzheimer's?
Yep, and they can do one portion of it. They can do the whole Alz Essentials plus CARES, and that's a certain fee, or you can do one portion of it and you will get, it's a certification. You have to take a test at the end and it's all online, which is really great. And then all of those free programs, once you've completed them and you fill out the survey, you can print out a certificate too, and that is very good. And we have lots of education that is both for professionals and families, and there are no fee, and for your own knowledge. We'd love to have you there. We love public health students. Yeah, thank you. And thank you all very much.
Thank you so much.
Thank you.
Something to remember us by. We usually just do
Oh
the
my
little
goodness.
thing, so
And
appreciate it. It's
purple, look,
Yeah, yeah.
we use purple.
That's your color.
That is so lovely.
Well,
thank you. That's
much.
so
It was
thoughtful.
great to
Very
have you.
thoughtful. Thank you very much.
Thank you.
You're welcome.
Okay, let's quickly go through some of the things that we heard in terms of our model. So we combine epidemiology and biostatistics. Can you tell me what you heard about Alzheimer's that reminded you of this? What are the epidemiological facts that you heard? Just one. Yeah.
Talk about that. It's the
Sixth leading cause of death in the United States. I didn't know that. That's pretty remarkable, given the focus we put on things like cancer, cardiovascular disease, obesity, diabetes. Okay. Did you hear anything about the environmental health aspect? No? Anything about the environment? There was, I meant to ask you this, Deb. There was a time some scientists thought that exposure to metals like aluminum might be, and people stopped cooking with aluminum pots and stuff. Is there anything to that? No, it didn't pan out. And yeah, they're always.
Yeah, but and I really don't know. But it will be interesting to see what happens over time.
Yeah, yeah.
There's
Yeah,
so many
lots of research. Yeah. Okay. Policy. What did you hear?
Oh, she said she's trying to get physicians to assist in screening.
Yes, like we have policies about screening for breast cancer, for example, and she said we don't have that for this, but they're trying to implement something. Okay, that's great. What about social and behavioral sciences? Oh, we locked our photographer. I'm gonna pass out a sign sheet because this is, so please write your name and pass it on. Okay. I'll get there. We locked you out? It's okay. What I did. Okay. So. I missed the social and behavioral. What did you say? Were you answering that? No? Well, we had a lot about that, though. The cultural stuff and the behavior, the moods. Yeah.
Yeah, I was going to say that people's behaviors change once they get dementia.
Right.
I guess that they may go from being sweet
Yeah, and there's, I mean, memory is so central to behavior, and the interpersonal skills and social networks that I know a lot of researchers in the School of Social Ecology and Social Science are trying to understand this, but it's an opportunity for research. Okay, in terms of the cross-cutting themes, communication and informatics, I mean, it's kind of apparent because they stopped speaking. And she talked about that. Diversity and culture, she talked about the differences in the support groups and the Latino population in particular being very different from, I think they want a service in Orange County, Korean, African American, or Vietnamese. Leadership skills, what struck you? Yes?
Like she was mentioning how caregivers themselves are actually getting up and like forming their own groups,
Yes,
organizing things.
yes, and they serve as catalysts for the organization and the support that they give. Professionalism, it's kind of obvious in her own role. Program planning. Yeah.
That has to deal with what she was talking about, the men's group kind of associated and doing towards the
And some things that they do at the national level, some things that they had to do locally. I don't know if she talked about anything they tried that didn't work, but I'm sure there are plenty of trial and error in creating a successful program. Public health biology. So I love the brain. So what is the roots of Alzheimer's? The plaque, what is the plaque actually? It's a deformed protein that kind of builds up, right? And there are rat models of this disease, but there's no perfect model for the human version, and we don't really understand why the protein becomes malformed. It's a lot of it. Systems thinking. Oh, I forgot to ask her one question. Does anyone know if insurance covers the kinds of visits they do? So Medicare covers, because Medicare is especially for people in this age group, and any kind of dementia, late onset disease will be one of their biggest, probably, expenses. And for such a comprehensive disease, you'd have to be very, very cognizant of the interactions between the home, the workplace, and the healthcare sector that they work with. And I can imagine that her role goes beyond just organizing these study groups, and she has to think very broadly about stuff like that. Okay, so thank you for your patience. I need to collect those sign-in sheets.
Do you want the IDs on them?
No, just your name. I have an Excel sheet with it. Are there any questions? Next week, I skipped over some of the slides on ethics, so I will save those for next week because I think we need more time to focus on that.